Dr. Abdalla will speak first, and she's delivering an update on dementia. We will have time for questions after her presentation. And then Dr. Alapat will be our second presenter, and we'll be covering BPSD and the challenges associated with it. That presentation is going to be case-based, and we really encourage you to get involved, interact, ask questions. Can we please welcome Dr. Abdalla for our first talk?
To start with, our mission to lead the way to end Alzheimer's and all other dementia by accelerating global research, driving risk reduction, early detection, maximum quality of care and support. And I start my presentation by this slide, because 99% of it is starting the primary care. It starts by you. This is why I start to talk about it today. All right. Together, we can ensure no one faces dementia alone. And this is highlight for the need for all Australians to reach out to the people with dementia in their community to let them know they are not alone. I want to remind everyone with Alzheimer Month, which is September, and especially this Alzheimer Day, 21st of September, which it will be Sunday this year. Let us remember those who can't remember. To start with my presentation now, I would like to talk about dementia. Dementia is a syndrome. It is not just one disease. It is not just one symptom. It is a group of the symptoms. It starts with forgetfulness, but unfortunately, it is neurodegenerative disease. It will progress. It will affect your daily life activity. You will start to be withdrawal. You will start to be social isolated. And it might end it to be having severe cognitive impairment and behavior and psychological symptoms of dementia. And actually, eventually can lead to death in the end. And all this happening due to the change in the brain. As we know, Alzheimer's is the most common type of dementia. And there is overlap between multiple types of dementia. Dementia, it is umbrella. There is multiple types. If you can look what I mentioned here, the type of dementia, we start with Alzheimer's disease, which it is 60–70% of the type of dementia. And usually how it started with amnestic cognitive impairment. It starts with forgetfulness, but it will not stop on that. It will progress to extent affecting your daily living activity. And usually it is geopathology in the brain. It starts your brain shrink, it starts to be atrophy, it affecting the temporal lobe and hippocampus. But if we move to vascular dementia, which is the second type of dementia, it affecting around 20–30% of the overall dementia. And usually it happens due to the change in the blood supply in the brain, making it scarring. You can see it in the MRI. This is why you start to forgetfulness. This is why you start to not retaining the information being provided to you. And there is another type of dementia, like Lewy body dementia, when you start having the memory impairment for a year or two, and then you start to have some Parkinson feature. You start to have tremor, rigidity, bradykinesia, and some visual hallucination and fluctuation. This is when we say this is Lewy body dementia. It might be a little bit more details to differentiate between each type, but sometimes it matters, because like Lewy body dementia deteriorate further than the other type of dementia. And you can see sometime in our letter, we might say Alzheimer's, but after time, other symptoms will appear. We might change our final diagnosis to Lewy body dementia. And when the brain is shrinking the frontal lobe, it can lead to frontotemporal dementia. There is other different causes of dementia, like alcohol-related dementia or Parkinson dementia, which you have the Parkinson disease for many years. It could be 10 or 15 years, and then you start to have the memory impairment, which is differentiated from Lewy body dementia. There is this other type like progressive cerebral palsy, but it is not less number, compared with Alzheimer and vascular dementia, which is a measure 2. We need to put our mind, not all the cognitive impairment is truly dementia. I will talk later on about some type of reversible causes of the cognitive impairment. As I mentioned, dementia, it is not just forgetfulness. It is a group of the symptoms. It varies from person to others. The progression also varies from some to others. They might have started with forgetfulness, but you become socially isolated sometimes. You become anxious. You are worried about your future. You are worried what will happen to you. And some of them, they develop behavior and psychological symptoms related to the dementia. It could be very aggressive or agitated, but it could be very mild. Just you feel lonely, you feel emotional, you feel isolated. And the researchers, I found there is 90% of the people suffering from dementia, they have behavioral and psychological symptoms during the stage of their disease. Initially, they suspected this is all related to the pathology in the brain, but subsequent studies, they found there is only 10 to 20% it is related to disease itself. All this challenging behavior, it is related to unmet need. When they are feeling they have hungry or pain or social isolated or just withdrawal or be separated from the loved one. Let us talk about dementia. It is a leading cause of death actually in Australia. For the female, it is number 1. And for male, it is number 2. As we know, the dementia, it is more common in the female, unfortunately, rather than the male. And believe me, this is underestimated, because me, I myself, I write multiple death certificates, I didn't mention dementia on it. However, the cause of the admission, it could be aspiration pneumonia. We say the cause of death is aspiration pneumonia. But why does the patient have aspiration pneumonia? Because they have dementia. They deteriorated and they died because of the dementia, actually. In US, the dementia actually number 6 leading cause of death, and probably because they have different health issues not being addressed similar to Australia here. All right, let us talk about how this disease happens, and this is specific for Alzheimer's disease. The hallmark of the disease, it is neurodegenerative disease. It is progressive disease. It's affecting the cortical and lead to atrophy. What's the pathology? It is simple. It is extracellular deposition of beta amyloid and intradeposition of hyperphosphorated tau, which affecting the brain cells, leading to scar. And the brain cells are just dead, and the synapses not talking with each other. This is why you forgetfulness. This is why you can't retain the information. It is a simple pathology, but unfortunately, this is the only leading cause of death. We don't have cure or treatment for it till now. They estimated there is 152 million patients will be diagnosed with dementia by 2050. Let us talk a little bit more about the pathology, how it happened. Actually, the change in the brain happening 20 to 30 years before the disease itself, which makes the treatment very tricky. However, given there is some modified therapy now in multiple studies and being approved in some countries as well, we might have future to treat this change in the brain before it damages the brain cells. If we look in this slide, here, when you do the biomarker to check the tau and amyloid, which it happened here 30 years before the onset of the symptoms, which it is not available now to order it for our patient, but it is available in some research centers. If you move here to beta amyloid, and beta tau, it happening around 15 years still before the symptoms, or 10 years before the symptoms. But what we're using now, we're using FDG PET scan, and we're using MRI, which is happening few years only from the onset of the symptoms. This is why usually the patient, when they reach us as geriatricians, the damage already, it could be happened in the brain. We hope, as I mentioned, in the future, this patient can be detected early if we approve for this biomarker and if this modified therapy, and we might prevent the dementia, Alzheimer's disease at some stage in the future. This is the progress of the dementia. It starts with cognitively impaired, but the pathology is there. And that it progressed to be mild cognitive impairment, mild dementia, moderate, and severe. And I keep telling my patient, everyone starts in severe dementia, actually started as mild cognitive impairment. But not everyone have mild cognitive impairment will end as severe dementia. Our goal to prevent mild cognitive impairment. By preventing one case of mild cognitive impairment, actually you're preventing one case of dementia. All right, let us now talk in a little bit more details. How I differentiate between normal aging and the dementia. It is very tricky in the elderly. Do you see this is aging? Which most of the patients, when you ask them, you said, yeah, I have memory problem, but just this is aging. When we can say this is aging, and when we can see, no, this is mild cognitive impairment, and it might progress to be dementia. Normal aging, when you're holding your key, and you want to go outside, you forget your wallet in the room, you go inside to get it, but when you come back, the key not with you. If normal aging, you remember immediately where is the key it could be. You can track your steps inside in the house. You will remember, yeah, I went inside to get my wallet. This means I will take the same way back to my bedroom or to my office, and I will get the key. You will get the key in 30 minutes or 1 minute. But if you have dementia, you will start to search your car. Where is the key? In your way inside, you will start to search in your kitchen, your bedroom. You will take 30 minutes to get your key. This is the dementia. It is normal sometimes to forget. All of us sometimes we forget. Imagine if you ask your husband, get the kids from the child care in the afternoon, and your husband forget. He will come back home, you will just tell him to go back and get the kids. But if you ask your mom to pick the kids from the child care, and she forget, the second day will take her for the GB to get referral for cognitive assessment. Not all the forgetfulness, it is dementia or cognitive impairment. Sometimes it happens, but you need to know how often it happens, how frequently it happens, how much affecting these patients. Here, when it is the pathology is there, but asymptomatic. No one worried about dementia, no one care about dementia here, but the pathology running in the brain. When you come to mild cognitive impairment, which early stage, which still you might be working, there is no problem, but you feel like you start forgetfulness, you start to use some strategy to remind you, you start to put some note, you start to use the alarm, you are aware you have problem. But when it progresses to mild dementia, this is when it starts to interfere a little bit with you. But still you're managing very well. Still you might be working, but there is a problem, you are aware about it, and the people around you, close to you, also they might be aware about it. But when it progresses to moderate dementia, when it starts to interfere with your daily life, when you start to drop a lot of things, when you have problem managing the complex task, when you have problem learning new tasks, and you start to rely on the other people. But unfortunately, when it progresses to severe, this is a time when you lose the ability to decide anything for yourself. This is a time when you start just to rely on the others. This is a time when we can't leave them alone. They need 24-hour supervision, either in the community or in the residential aged care facility. We know that dementia, there is no cure, but we need to do something to know how we can help these people. This is why all the researchers looking for risk factor, who could develop dementia, they're looking for the risk factor from the different angle to know exactly what the causes of this dementia. Let us talk about common risk factor of dementia. As we know, there is modifiable risk factor and unmodifiable risk factor. Modifiable risk factor, it is a non-modifiable risk factor, it is the age. We can't do anything about it. We know the Alzheimer's disease is more common with the aging. There is 1 in 10 if you are 65 years too old to 74, but 1 in 3 if you are older than 85. This means aging, it is a common risk factor for developing Alzheimer's, and unfortunately, we can't do things about it. The other risk factor, familiar, there is some genetic factor, it could be around in the family, and this is mainly common in the early onset dementia, as well as the family history. And I will add another thing, being female. They found the female, it is more common having dementia than the males. And the reason for that, because simple, they live longer than the male. And the other things, they progress faster than the male. They said there is theory due to change of the hormone after menopause. Let us talk about the modifiable risk factor, which is the things in our hand, we can work on it. We have diabetes. All of us, we know the patient with diabetes, their brain aging 10 years more than the other non-diabetic patients. Hypertension, especially in the middle age, smoking, obesity, traumatic brain injury, sedentary lifestyle, social isolated, and mental health problem, all it could be risk factor, because simply they become isolated, they not interact with other people, which this is one of the most important non-pharmacological intervention when you're managing the patient with the dementia. This is just a report from Lancet in 2020 about modifiable risk factor. This is not the common risk factor. This is the modifiable risk factor. If you have a look, you will find hearing loss and hearing impairment. It is the common things you can modify it. It is not the common risk factor, but it is a common risk factor you can modify it. For that reason, please don't forget to check the patients. Ask them about their hearing and their visions, which is the common symptoms with the aging. It can matter, with the simple strategy. Now let us talk about what is the treatable cause of dementia. You remember in my first slide, I mentioned there is some causes, it is not true dementia. It is cognitive impairment, but it is not true dementia. And in specific in this one, I would like to stop in the obstructive sleep apnea, because almost 15 to 20% from my patients, they come with cognitive impairment ended as obstructive sleep apnea. It is very common, and you don't need to be obese to have obstructive sleep apnea. Anyone have risk. If you wake up in the morning, you are not fresh, you are fatigued, and you tired, you snore, test yourself for obstructive sleep apnea. Or ask your patient to be tested for obstructive sleep apnea. Other causes are depressions. A lot of people, they refer for us for cognitive impairment. You do the test, there is significant cognitive impairment, but it could be all related to depression and anxiety. You need to address that first before you give final diagnosis for them. Medication side effects. This is a common things can affect the memory. There is a lot of medication being built over years and years. We have some patients, they have 20 medications, they take it every morning. The first things we do medication review to stop all the medication you don't need it for 85 years old or 90 years old before you make any diagnosis of dementia. Other simple things like thyroid, hypothyroidism, which is one of the screen. Usually we like to have thyroid function test, B12, to make sure, because this is very simple, reversible causes of cognitive impairment. I have patient come to me, one of lady come to me in the clinic, her TSH actually, it is 100. And she make a lot of improvement after we adjusting that and managing with just thyroxine replacement, and she feel better in herself. Excessive alcohol as well, it is a very common cause to lead to cognitive impairment. Now, we talk now about the dementia, what is it, what's the common type of dementia, what's the risk factor. Now I want to explain what's the benefit from telling the patient you have dementia. I know I don't have cure, I don't have treatment. Then why I want to tell them you have dementia? Why I want them to be more anxious maybe when you add for them extra diagnosis? Just look to this patient, how eager he is, looking to the doctor, want to know what's going to tell him. Look to the daughter and the wife. They are very keen to understand why their dad changed, why his behavior changed, why he's not become interested as before. It is really important to do diagnosis early of dementia. Early you do it, it is better. Because when you do it early, you support the patient more. We don't want to leave anyone behind because he have dementia. I put 9 causes why I do early detections and the benefit from diagnosis and telling someone you have dementia. However, if I want to subdivide it, it will be 30. First of it, things, management of modifiable risk factor. When the patient become aware about some cognitive impairment, when you start to investigate for cognitive impairment, you start to look to the risk factor, which we talked about it before. Diabetes, hypertension, smoking, alcohol intake, all this you start to look for it. Blood sugar, you adjust the blood sugar more and you divide it. If they didn't come with cognitive impairment, they might not see GP for a long time. They might no one address that at all, or they come for different things very quickly and they leave. They reduce an anxiety about the symptoms. Believe me, when we're seeing the patient in the clinic, a lot of time couple will come. The wife very, very angry why the husband changed, why he is not loving her as before, why he start not talking with her much, why he start not doing work at home. And they become very angry and aggressive during the first consultation. But you can see how that change after you explain for them what's the problem. After you show them the MRI or the scan and show them how the brain is changed already. This is why your husband changed. Is still he loving you, but there is problem in his brain. This is why it's happening. And usually the daughter comes with her mom. She is very upset about mom behavior. She becomes stressed, agitated, not like us when we come to visit. She is not good with the kids as before. And they get very upset. Why is that happening? Because mom have dementia. When you explain it, when they understand it, everything will be fine for them. All that relationship will come back again. Evaluation of other causes. This is the not true dementia. Sometimes you will look for obstructive sleep apnea. If you didn't come complaining of the cognitive impairment, or if we didn't look to the cause of the cognitive impairment, probably the obstructive sleep apnea will not be diagnosed and will not be treated until it damages the brain. Hypothyroidism, ischemic heart disease, everything. It will not be look for it to reverse that causes. Better management of comorbidity. I think this is a little bit overlap. When you have heart problem or if you have diabetes, you start to be aware about that. You start to eat healthy. You start to do some exercise. You start to be a little bit more active because you know this all it will help improving your cognitive. You start to be more social, interact. Complete safety assessment. This is really important. I hate someone to come to me with advanced dementia. It is too late to ask them to decide for themselves anything, and it will be in the other people's hand. I like to see the patient with cognitive impairment early, to give them the chance to decide what they want, to give them chance to complete their power of attorney, to do their advanced health directive, to decide, to plan their future, what they want. rather than no one aware. And it is very hard for the family, by the way, as well. A lot of patients, they prefer to know the things and adapting themselves for it, rather than suddenly they live in a different state and you come and tell them, your mom has dementia, and this is advanced dementia. Get access more about safety assessment. In the other safety, you assess their safety in living at home. You do ACAT assessment. You get for them services. You get for them support, rather than failed living at home, ended in the hospital, staying for a couple of months until you get for them placement. But if you know this patient will go that direction, you'll organize all that. You transitionally very smoothly from the community to the nursing home and avoid them being in the hospital. Other things, you assess it in that driving. Most of the people, they have advanced dementia, still driving. Why? Because no one knows they have dementia. If we know they have problem, probably we'll talk with them about. Worst scenario, we'll ask them to do OT driving tests to make sure they are fine or not. But a lot of people not being diagnosed and still driving. Get access to the research, which we don't have a lot of things to do with it here in Toowoomba, unfortunately. But it is one of the opportunities for the patients to be early identify if this patient have cognitive impairment or not. Access the option of the treatment. And the option of treatment, we know we have few treatment we give it. We know it will not cure, but still we believe it might slow the progression. And a lot of time I explain for my patient, yes, I'm happy to give you donepezil. You might come to me back in 6 months telling me it not make any sense for me. I explained for them, I knew that it will not make change, but I don't know if you are not taking it, how fast you will progress. If not giving you side effect, usually I leave it. And they found the people on donepezil or cholinesterase inhibitor, they are less likely to have antipsychotic medication in the advanced disease. Advanced care planning is very important. If you detect dementia early, you involve the patient, you involve the family to complete all this advanced care planning. And the last thing, the cost on the health system. Treating patient with pneumonia, 85 years old, with pneumonia, it is different if you're treating 85 years old with pneumonia and dementia. The length of stay is double, the complicated is double. Then now we know a little bit more what to do and why we need to tell the patients you have dementia. Then how you will know this patient is the one I need to assess for dementia. I will not ask you to discuss that with every patient you're seeing older than 65. It is impossible. But who is the patient you will think, this patient I need to stop a little bit and ask about the warning symptoms or signs of dementia. Usually 3 ways for you to look for this type of patient. Either the patient come by themselves and telling you, I have problem, which I like to see this type of patient because definitely it is very early because they come self-presented, subjective cognitive impairment. They are worried about they have some problem. And this is the time you start to modify all the risk factors. It might not end it they have cognitive impairment, but at least it's been checked. And it is not bad at all because subjective cognitive impairment, it is overlapping early Alzheimer's disease, actually. Don't ignore the people who have subjective cognitive impairment. Anyone have subjective cognitive impairment need to be assessed. You need to look to the risk factor. It might be anxiety, it might be depression, but it could be early Alzheimer's disease when the pathology starts in the brain. I will go back to my slide. Yeah. Either the individual come and tell you, I have some cognitive impairment, or the family member, the neighbor, they ask the patient, you have problem. We notice there is some change in you. You need to be checked. You have some memory problem. Or you ask clinician, you notice that there is some problem with the patient coming to you. Lady coming to you every time alone. You give her some information coming without the list of her medication. You ask her, next time when you come, bring your medication because I want to have a look. She come next time without medication, without family, without anyone with her to know what's happening. She start to missing some appointment. You start to give some informations every time they coming. Check next time when they come back. Did they remember the information you provided for them the last visit or not? This type of people would need to be assessed. All right. Now, let us talk about the step of diagnosis dementia, where I am going to start. You will start first by identify which person you think this patient, it could be cognitive impairment. I need to look for that. You will start with history taking. History is very important. I will go through this slide just to show the way I assess my patient when they come in the clinic. Usually I introduce myself, reassure everyone this appointment a little bit longer. It takes time, but I need to go over everything. Reassure the patient, because usually they are very worried. They bring them now for assessment, and they're going to tell them you have problem. Reassure them, reassure the family. Usually I try to put the patient and family all in front of me. Then I can look to all of them in the same time. You will look to the facial expression for all the family members when the patient talk, or the opposite. Start with the patient, ask what's the problem, ask her, look, I'm going to start with the medical history first to know what's the problem. You know, because the brain, we can't separate the brain from the body. I need to check everything in you first, and then we'll come to the brain. You start with the medical history. Yes, in the referral, all the past medical history will be written, but let the patient talk. Tell the family, I'm going to talk with the patient first. Give me 5-10 minutes. Don't worry. Even if it is not wrong, I will be back to check with you. Give them chance to tell you what's the medical problem. If they're telling you 90% from their medical history, I will be comfortable. This is not bad at all. But if they can't tell you 1 or 2 from 10 medical history, this is a worry. Listen to them, and that actually it will help you what type of cognitive tests you need to do to them. After that, listen to the family. You need collateral. You can't go all with the history just the patient provided to you. You need to take detailed history of the medical problem, what's the situation, how long this memory problem started, how they manage it at home, what help they have. After that, you start to do physical examination. Physical examination is very important because you might get tremor, bradykinesia, and rigidity. It might direct you. Is this low body dementia? Or this is Parkinson-related dementia, and you start to dig more in the history. You might find some localized signs. This patient might have a stroke or TIA, but they are not aware, you know. Or the patient have tumor. Sometimes in the brain he have weakness, but they come with cognitive impairment. We don't know what's the problem. Don't forget, during your assessment, check the hearing and visions. After that, look to the pathology and the blood tests being done by you and referred to us. You know, it could be hyperthyroidism, it could be chronic kidney disease, it could be liver impairment, it could be encephalopathy, the symptoms of confusion and forgetfulness. All this is important. When you do all this history, you will get idea where I am starting. If I am starting in very high level of the test, this patient really good, I need to go with something very advanced, or this is most likely it is an advanced problem, I need to go with a simple test. There is few tests available. Many mental state examination is done on most of the time in the general practice as well as the MOCA. Clock drawing, sometimes it is very good to know exactly what the patient is thinking, you know, very quick test and screening test. Sometimes if it's advanced dementia, I do MMSE and I do clock drawing just to see what they can do for me. Sometimes I get just some pictures, you know, with multiple pictures, photos there. I ask them, could you name for me this picture? If they name 10 out of 12 pictures, still I will have idea where this patient is sitting, you know, but if they can't name for me anything, or 1 from 12, I will be very worried. And then more detailed tests you do which depend on the level of the education of the patient and the level of the cognition you estimate it will be during your conversations. There is multiple other detailed tests like R-bands, which is done by the psychology. The appointment usually is long because sometime after all that you feel like this is more depression or an anxiety. You need to do geriatric anxiety inventory. You need to do geriatric depression scale to see where is the problem. After that, you will start to think, what type of neuroimage I want. Most of the patients, they come to us with a CT scan, which is really good because it will rule for you the big things, either big tumor or mass, or big bleed, or big old, in fact. But when they come to us, usually, unless it is very obvious from the CT scans, there is severe brain atrophy, severe hippocampus atrophy, or the patient have advanced dementia, we might make our diagnosis just from that. We don't go with the further image. But sometimes we go with doing MRI. And this is the MRI for the people with Alzheimer's disease. This is the hippocampus. You can see this is the normal healthy brain. And here it's almost gone. This is MTA4, severe hippocampus atrophy. You can see how the brain shrink. When we move here, this is FTG PET scan, which you see the hypermetabolism in the scan, and it helps you to differentiate what type of the dementia. Is this Alzheimer's disease? It is frontotemporal dementia. If it is Lewy body dementia, all it will help you. These two modality of the scan, still we don't have it here in Toowoomba yet. I think in the Brisbane, the amyloid PET scan, it is available in one center, and it's very expensive. We never sent patient yet there. But one day it will be available. Other things I want to mention about it, sometimes some patients, they come with us with this PET scan. This PET scan, yes, it's been used before. It might be helpful. But PET scan, it is better, to be honest. If you do CT scan, you don't need to order the PET scan, because sometimes it's PET scan. Sometimes we do just the MRI. It might give us diagnosis, or we might need to go further doing FDG PET scan. All right, this is a biomarker which will be changing the game when we reach that stage, because our aim, early detection, we need to know the people, they have amyloid and the tau deposition is very early to be managing them, especially with this new disease-modified therapy. It could be very simple, either by saliva or from the CSF or from the blood. But I think this is long years to go. I'm not sure it will be in our generation or not. Then what's the treatment? Now, we told the patient you have dementia. We told them we can stage it. Most of them, the first question they ask you, what is stage of the dementia? You need to explain them. To go back to that green line, which I explained it, all the green is fine. It is either preclinical diagnosis or early or mild cognitive impairment. But it will be worried when they turn into the blue color, where it is a severe type of dementia. Cholinesterase inhibitor is available. The other things, anti-myeloid therapy, which is a monoclonal antibody, it's been approved in some country, not yet in Australia, but there is a lot of research. It definitely removes amyloid from the brain with a PET scan, but we are not sure how much it will change in the memory or reverse it. But my belief, if this is all done early stage, it might change. Very expensive. It needs around $60,000 per year for each patient. I want to stop in this slide with the obstructive sleep apnea and the dementia. It is very common. It is very common. You need to look for the sleep apnea. As I mentioned, you don't need to be obese. If you have symptoms, if you are fatigued, please test your patient for obstructive sleep apnea. Now there is home test. It is available. It is bulk billing. You can do it first, at least as a screen. If it comes totally normal, it will reassure everyone. This is other slide about the metabolism and dementia. Interesting, they found 39% of Alzheimer's disease, the pathology behind the hyperinsulinism and insulin resistant. For that, changing your lifestyle is very important. It is very important to control the blood sugar. And some research, they call Alzheimer's it is type 3 diabetes because they thought there is huge link between the hyperinsulinism and Alzheimer's. I would like to talk about this study, which is something very simple, and it can be done in the general practice. These people, they don't need to be involved in the research program or big study to have this. It could be done in the general practice for everyone. It's called Sprint Mind. Sprint study been started many, many years, I think since 2007, what is it? They select randomized group study with 2 groups of people. They control the blood pressure very tight for one group less than 140 and the other group less than 120, and they see what's the difference. They found there's huge difference of preventing ischemic heart disease, preventing heart failure, and cardiovascular risk reductions. After that, they added Sprint Mind to see if that also can affect the cognition or not. Initial release of the study, they said there is no change in the cognitive improvement after you controlling the blood pressure, which is they follow the patient around 4.9 years. However, in December 2023, there is more study come out. They found there is actually huge improvement in the cognition if you're controlling the blood pressure. But they eliminate the people, they have diabetes. When they remove everyone have diabetes from the study, they found there is huge improvement. And this is linked me to the slide I did it before, which is the hyperinsulinism and insulin resistance is playing a very big role in the cognitive impairment and Alzheimer's. It is very easy to control that. Check your patient, make sure the blood pressure controlled. It will help them. The other study, which is very simple study, it's called FINGERS, which it is Finnish geriatric interventionist study to prevent cognitive impairment and disability. It happened in Finland initially, but it became all over the world, multiple countries. Actually, this one, it is from 2023. The one from 2024, it is a little bit blurred. I couldn't put it here. There is multiple countries added in this study. There is 4 interventions, they do it, and they found there is huge improvement. It is very simple. We can introduce this for our patient in the general practice and tell them about it. And what is it exactly? They're doing some specific type of diet. It is not keto diet, just healthy diet with low-carb diet. They're eating more nourished food with low-carb diet. But still they have carbohydrate. Don't get it wrong, it is not keto diet. It's just low-carb diet and healthy nutritional food. They involve this, we can go back to the other slide. They involve these people in a specific exercise program. It could be a little bit, when initially I looked to it, I feel this is a little bit too much, but actually they do it as tolerated, whatever they tolerate. They're doing muscle strength program twice a week and anaerobic exercise 3 to 5 times a week. It's very short time. There is no limited how long you need to do it, but you do it as you tolerate it. And this is intervention actually for this group of people it's done over 2 years, and they followed them for 11 years after the study. Social interactions, it is very important. Actually, they offer for everyone 10 psychology sessions. And there is 3 exercise programs done every week on the computer online for cognitive behavioral therapy. As well, addressing the other comorbidity and risk factor. And they found there is 25% greater improvement in overall cognitions, and 40% in the complex memory task, and 150% in the speeding process. It is really helpful and very easy. Talk with your patient about it, physical exercise, healthy diet, social interaction. And this is actually non-pharmacological intervention, which we're talking about it. I talk with my patient about non-pharmacological intervention more than the treatment. Social interaction, get out, talk with other people, involved in some activity, walk outside. Just imagine you are staying in the room, just by yourself, your brain will use to this room very quickly and stay calm. But if you just open the window or you open the door and get out, you will see 100 things can stimulate your brain. It is very important to encourage your patient to get out, to talk with other people. It is never too early to detect cognitive impairment or to talk with the patient about cognitive impairment. At the same time, it is never too late. It never be too late to help the patient and support them. It is a very long process for them. Whatever the stage of the disease, still they get the support and help from us. Let us all make impact in fight to end Alzheimer's. The aim, it is prevention and early detections. Whatever you do for them, it is real. It is important, and it is matter for them. And our visions, world without Alzheimer's disease and all other dementia. Thank you very much.
Thank you so much, Dr. Abdalla, for that. That was amazing, interesting update. I think the key learning point there is that early detection and sleep apnea. We're opening to the floor for questions, specifically for this talk. So there, if you've got sort of BPSD questions, if we can save them for later. But has anyone got any questions?
How helpful is the COG-D risk in detecting early dementia?
Look, all the cognitive tests you do it is very important. It will tell you, but it is varying. If I have someone very highly educated, I have lawyer. If he scores 30 out of 30 in any cognitive test, I'm not going to tell him you don't have problem. If there is history concerning, it is a problem until you roll it out. You know, we get referral for the people's MMSE 30 out of 30 or MOCA 30 out of 30, but it is problem. I start sometime donepezil for some patient with MMSE of 30. It doesn't mean they don't have dementia. You know, the history is very important. See, if the patient have problems themselves, if they have concern or having symptoms, you need to look for it. You need to investigate it.
Is there any evidence that treating obstructive sleep apnea actually will help cognitive impairment?
Yes, it will help. I remember I have one patient, she lives outside of the Toowoomba. They are very wealthy couple. They have very big farms. They live all of their life in the farm. And the wife, suddenly she is around 70, but very young and very fit for 70. She decided, I want to do something for myself. I want to be involved in some exercise program, but I'm a little bit social isolated. The husband very busy with everything. She decided to come to Toowoomba to do some hydrotherapy. The first day she comes, she crashed. Again, the second time when she comes, she have car accident and immediately be referred for us for cognitive impairment. We did for her the test. She scored very good, actually. But she determined she have problem. She knows she have cognitive problem. And husband also, they said, definitely she had problem. We did for her a sleep study. She had severe obstructive sleep apnea. And she managed to get CPAP machine. And she come for follow-up. There is huge improvement. To extend her husband, very happy about that. He took her for holiday to Canada. And they come back, you know. And they're very excited how this has changed their life. However, saying that, I told her, despite, yes, we didn't give you diagnosis of dementia, and she scored 100 out of 100 actually in ACE after she come back. But I explained for her, still you are very high risk to develop dementia in the future. Why? Because she has extensive small vessel disease in her MRI. And this is probably because obstructive sleep apnea not been diagnosed for a long time. You know, the brain, it is similar to any part of the body. It ages, you know. The change is happening in your skin, the change is happening in your face with aging, also it happens in the brain.
I'm only asked that because with we know that you have an increased risk of cardiovascular disease with obstructive sleep apnea, but a lot of studies show that treating it actually doesn't improve your cardiovascular outcomes. So just wondering whether there was any evidence.
Look, if the damage already happened in the brain, yes, unlikely they will get better. But if there is no damage already happening in the brain, they're getting better. They improve because mainly the symptoms is confusion rather than dementia. They feel fatigue and confused, can't concentrate. This is their main symptoms. We never give them diagnosis of dementia. The confusion, their conditions, your life, they improve. But I agree with you, if the damage already happened, using CPAP machine, it will never improve, and they don't use it because they don't like it, and they put it in the night. After 10 minutes, they remove it, and it never been back. And the partner working all the night try to put the machine. It will not work. When they reach that stage, sometimes I said, don't worry about the machine. Just put it in the night, but if you remove it, you don't need to walk in the night to put it back.
You also mentioned very briefly, I only just caught it, that use of anticholinergics lessens the need for antipsychotics.
Yeah.
Can you comment on that?
Yeah. Couple of years ago, to be honest, when I am still in my training or even before my training, we don't use the cholinesterase inhibitor a lot. Either we're saying, this is mild cognitive impairment, not interfering with their daily life activity, and we are not giving treatment. Or this is too advanced dementia, we don't need to give it. But now it changed. Cholinesterase inhibitors, they found the people on cholinesterase inhibitor less likely to have PTSD symptoms and to be needed antipsychotic.
What about with memantine?
Memantine, usually we give it in the more advanced type of dementia. I have no specific study about it, but for cholinesterase inhibitor, there is multiple study being published. It reduces the risk of using antipsychotic.
Any further questions, guys? Okay, well, we'll leave it at that. Again, thank you so much for that presentation. That was amazing.
Thank you very much for your time.